Meeting is being recorded.
Are you able to see?
Yes.
Yes.
Make it bigger. Are you guys able to see the full screen?
Yes, we are.
Yes.
Okay, perfect. All right. So, Marshad, if you want to let us know when we can start, go ahead and do that. And I can just kind of do a little intro if you'd like. Just let me know whenever you're ready.
I would say give it about 2 more minutes. We are still letting people in.
Okay, perfect. Sounds great.
About 2 minutes and then I would say get started.
Thank you.
Okay, so what I'm gonna do is that I'm gonna sign out. We're projecting it with my resident onto a larger screen. Having all the little, our cell phones on kind of like cause quite a bit of feedback. So I'm gonna sign out. It's Dr. Jacques. Okay, but all of us are sitting together. Thanks.
Ruba, if you want to get started, we have about 29 people in so far.
Great. All right. Well, thank you all so much. We're really excited to be able to partner with the Epilepsy Foundation. So thank you all for joining us. This is a really great topic that we have two of our fantastic doctors and a nurse practitioner from Memorial Neuroscience Institute. So I will let them kind of really do their introductions, but I do want to let everyone know that we do have Dr. Zakaria, who is our director of our Neuroscience Institute program, and Fiorella Saka, who is a nurse practitioner that's worked with us in Memorial Neuroscience Institute, who specializes in epilepsy. So I'm going to go ahead and let them take it away. Thank you again so much for joining in. We're excited to see so many of you on this webinar during this time as well. So go ahead and I'll let you guys take it away, Fiorella and Dr. Zakaria.
Good afternoon, everyone. Can you hear me?
We can. Yes. Thank you.
Okay, perfect. So again, I'm Dr. Zakaria. It's just a pleasure to be here today. I know you guys are busy. It's Monday, but I appreciate your time spending your lunch break with us. I have Fiorella Saka to help me with this presentation. We are the epilepsy program at Memorial Neuroscience Institute. As you can tell, this reflects the commitment that Memorial has taking care of patients in the community, especially patients with epilepsy. And over the last few years, we have seen huge growth in the program. Part of it is the support and commitment that we have from Memorial Administration and Memorial Healthcare System to help us to grow and provide our patients in the community with the best and the most advanced treatment option for patients with epilepsy. So without taking too much of your time, I'm going to try to focus on the topic for today, which is epilepsy and pregnancy. And I think that's a quite important topic because when you have seizures and you're diagnosed with epilepsy, this can eventually limit a lot of your, affect your quality of life. And one of the things that we need to talk about is how we can improve the quality of life for our patients who have seizures and epilepsy. And one of the most important aspects of the quality of life is just to be able to have family and for the women to get pregnant. And there's a lot of concerns, I guess, from a lot of patients with epilepsy when it comes to, can I get pregnant? What's going to happen to the baby? What's going to happen to my seizures? What's going to happen to my medications during pregnancy, which I think is very important questions that we will try to address and we try to cover today. We will try to talk for maybe 20 minutes, half an hour, and then we would love to hear from you, whether it's a question or your experience or any kind of comment. We would like to keep this as interactive as we can. So I will start with the first slide. I'm going to ask Fiorella to go over the slide, and then we will alternate every other slide talking about some of these questions that I mentioned.
Hi, thank you for having me here as well. So to get straight to the presentation, we're going to discuss that epilepsy is not longer considered a contraindication to pregnancy, and over 90% of women with epilepsy have good outcomes. They can achieve their desired birthing method. And this is something that I would like to share because motherhood can be very exciting for a lot of us, but it can be very stressful, especially if you have epilepsy. So coming with a discussion for preconceived planning with your care providers is ideal. Next slide, please.
So like Fiorella was saying, she just gave us the conclusion of the presentation that 90%, maybe more than 90% of women who are interested to get pregnant while they have seizures, 90% of them will have a normal pregnancy, they will have a normal delivery, and they will have a normal baby. So if there's any takeaway message from this presentation and all this slides, I want you to remember that there's a very large, or there's a huge chance that you will be okay. You will have a perfect pregnancy, and your seizures will be under control, and you will have a normal baby, and you don't have to worry too much about that part. But the most important factor that helps to achieve this outcome is communication with the physician that's taking care of your seizures. I think the more we are prepared for the pregnancy, and the more we are communicating with our physicians who are taking care of the seizures, I think that's the most important factor in order to have a safe pregnancy, normal delivery, and a normal baby. So remember, the planning for pregnancy, I tell my patients that if you really want to get pregnant, you have to tell me like at least 6 months before you start planning or before you wanted to have the baby. We typically don't like a surprise pregnancy because we will be running short of time. But like I said, the more you communicate, the more you prepare you and your physician for this pregnancy, the higher and higher chances that you will have a normal pregnancy and normal baby and normal delivery. There's a lot of concerns and a lot of misunderstanding about the relationship between pregnancy and epilepsy. A lot of my patients come and they say that because I have seizures or because I have epilepsy, I cannot get pregnant, and I will not be able to have a normal pregnancy and normal child. And that's completely wrong. Like I said, 90% of women with pregnancy, with epilepsy, they will have normal pregnancy and normal delivery. Another thing that I hear from my patients, sometimes they say that I'm very scared about the medication. I completely understand. I completely see the concerns that
epilepsy meeting.
I see that I completely agree, or I completely understand the concerns that a lot of pregnant women will have about taking the medication. Actually,
Dr. Zakaria, you guys went on mute.
so how long I was on mute?
You completely understand about epilepsy. I think that's what you, or about pregnancy. That was the last thing you said.
You can hear me now, right?
We can.
Okay, perfect. So I was saying that I completely understand the concerns that a lot of women will have about medications and pregnancy. And I would tell you, in fact, I had a patient came to my office 2 weeks ago, and she told me that she's pregnant. She's 2 weeks pregnant. It was not a prepared pregnancy, and she told me that the second she knew that she's pregnant, she stopped her medication, and that was a very major concern to me, because yes, I understand that medications, we need to be concerned about the medication in pregnancy, but also we want to be concerned about having seizures during pregnancy. So both will not be a good thing for the pregnancy and for the baby. So again, if you get pregnant and you're taking medications, please do not stop your medications on your own, please, because the risk of having seizures will be a lot worse than any potential risk of the medication on the pregnancy. Reach out to your physician right away. Tell them that you think or are pregnant, and I'm sure the physician will be having that discussion. That emphasizes the importance of preparing for that pregnancy before you get that surprise news that you are pregnant. The third concern or the third question that we hear from our patient is, will my baby have epilepsy? And I'll just give you that answer right now. It's very unlikely, except in very few types of seizures where there will be slight increase in the risk of having epilepsy in the baby. But 99% of the times, your baby will be okay. He or she will not have epilepsy or seizures. The next question is, I cannot breastfeed while taking medication. And that's also something that's not true 100%. We want you to breastfeed. There is no major contraindication to breastfeed while you are taking the medication. It all depends on planning the right medicine with the right dose, right milligrams, and most of the women will be able to breastfeed after having the delivery. And then the last question is, I will have a C-section, and that's also completely incorrect. Most of the deliveries will be normal deliveries. It's interesting that a lot of time the OB doctors will be calling me and saying, oh, can we do a normal delivery or C-section? And I would say, this is completely up to you. It's completely related to OB indication, but from our end, from epilepsy perspective, there is no reason to do a C-section just because of epilepsy. Typically, we let all the women, pregnant women who have epilepsy, to have a normal delivery if there is no OB indication for a C-section. Next slide.
Okay, so risks during pregnancy. To reiterate, most women are able to have a healthy pregnancy and baby, but epilepsy does raise the risk for certain complications during pregnancy. These complications are preeclampsia, which is a high blood pressure during pregnancy. Miscarriage rate also increases. Premature delivery can also be seen. Hemorrhage, stillbirth, an increased maternal mortality, low birthing weight. Therefore, it's important to, again, we cannot say this enough, to come for regular care and having that discussion, getting lab work done, and which we'll talk about it in the next slide. Next slide.
So it sounds, this kind of conditions sounds scary, which I agree. Like I mentioned, 90% of the pregnancies will be just fine, and they will have a normal delivery and normal baby. However, there is increased risk of some conditions or complications that can happen during pregnancy. And those are the 10% cases that I mentioned. So some of the complications that can happen during pregnancy is some women might lose the baby, miscarriage. There might be increased risk of a premature delivery, having delivery early on before the 38 weeks or 36 weeks. There is a risk of bleeding from the uterus before or during the time of delivery, mainly related to the some kind of problem with the placenta that can lead to the bleeding. There's also risk of having the death for both the mother and the baby. Those complications are rare. Again, the more we plan for the pregnancy, the more we will have good outcome and normal delivery and normal baby. But do they have does pregnancy and epilepsy slightly increase the risk of some complication? The answer is definitely yes. But those are things that we can treat and prevent with planning the pregnancy. So what are the things that women with epilepsy, they know that they are a higher risk of this complication? So what are things that some women with pregnancy with epilepsy, that they will be at an even higher risk of having complications during pregnancy? The most important one is the seizure frequency. Before pregnancy, look at the word before. The more control of the seizures we have before pregnancy, the more likelihood that we will have a normal pregnancy and normal delivery. So if you are seizure free before pregnancy, then your risk goes significantly down during pregnancy to have any complication that we just mentioned. However, if you're having 2 or 3 seizures a week before pregnancy and you get pregnant and it was a surprise pregnancy, then there is a higher risk to run into some of these complications that we mentioned before. The second one is the compliance with the seizure medication. Like we mentioned before, do not be scared of the seizure medication. Even when you get pregnant and even when you are not planning for this pregnancy, do not stop the seizure medication on its own. We know that stopping the seizure medication sometimes can lead to what we call a status epilepticus, which means non-stop seizures. So when this person I referred to a few minutes ago, she came to the office. She stopped the seizure medication 2 weeks ago when she knew that she's pregnant. She is at a very high risk that she will run into what we call status epilepticus. We mean that she will have a seizure and the seizure will never stop, and it will be very hard to control the seizures. And you can imagine that effect on the baby. So do not stop the medication on your own. Even if you get pregnant, reach out to your doctor. He will handle this situation. But things that you can do to control the seizures or to reduce the complication during pregnancy, try your best to get seizure free before pregnancy. The second one is be sure you take your medication. Of course, the more medication you take, the higher risk of having complication during pregnancy. So if someone taking one medication, seizure free, no seizures, and no side effect from the medication, and it's one of the safest medication for pregnancy, this person will, I assure you, there's a very high chance this person will be fine and will have a normal pregnancy and normal delivery. But if someone is having a lot of seizures, taking a lot of medications, not very compliant with his medication, that's a patient I will be very concerned that she will be having a lot of seizures and problems, complications during pregnancy. And don't forget that there's a lot of changes in pregnancy. So when the woman gets pregnant, there will be a lot of changes in regard to the way that her body is dealing with the medication. So that's something that's very important that we will be talking about in the next few slides, is how the pregnancy will change the way that the body will be dealing with or will be handling the seizure medication. Next slide.
So are anti-seizure medications safe during pregnancy? There are multiple studies showing that there are high risk for fetus malformation during pregnancy with the use of anti-seizure medications. Those medications are known as valproic acid, for instance, phenobarbital, topiramate. That's why typically in a pre-conception appointment, we try to make changes to minimize these risks. Also, the risk of someone taking multiple anti-seizure medication can also increase the risk for malformation. We also go through a reevaluation of the diagnosis, ruling out other symptoms that could look like epilepsy or non-epileptic spells, movement disorders that could possibly change the way we treat you. And this risk of malformation also increases with the higher the daily dose at conception and the more anti-seizure medication the mom takes. There are certain anti-seizure medications that carry higher risk for cleft lip or spina bifida, for instance, or bleeding disorders in newborns. But these again can be addressed, and we can make changes to minimize the risks. And we also recommend to minimize the risk to start moms on prenatal vitamins early on, vitamin D, folic acid supplementation that could strengthen the spine of the baby. Information. Next slide.
I think there's one more slide before that. Yes, thank you. So I guess the way I look at it with regard to the medications, which medication is safe, which one is not safe. We have to look at the medications, the seizure medications during pregnancy as a spectrum or a wide range of options. There are medications that are completely safe and it will not increase the risk of problems for the baby. Some example of this medication that are extremely safe include levetiracetam or Keppra, also Lamictal or lamotrigine. So those are medications that are very safe, and we would love to see every pregnant woman as she is preparing for, every woman with epilepsy as she is preparing for preparing for pregnancy to be on this medication. At the to the opposite extreme, there is medication that are really not good, and we should try our best to change them before we get pregnant, because we know for a fact that they increase the risk of problems. Example are the Depakote or valproic acid, phenobarbital, and dilantin. So those are medications that we don't want to see as we are planning for pregnancy. We want to change this medication during that time of planning for the pregnancy. It will be very hard on us and on the patient to change those medications after the pregnancy is happened. So again, we cannot emphasize how important it is to plan. And part of the planning, you tell me, so what's the planning? How we can do this planning? Planning will be to be sure that you are on a safe medication. And if you are taking one of those not safe medication, your physician will be talking to you about switching the medication, being sure you adjust to the new medicine, being sure that the seizures will continue to be under control on the new medication before you get pregnant. One of the most interesting facts that I want you to be aware of is the Depakote is very bad for pregnancy. And what we found is that it's not only affecting the baby in uterus when the mom is pregnant and the baby is growing in the uterus, that the Depakote effect on the baby will not only be during that time, but it will continue to have the bad effect all the way till he is 2 or 3 years old. Imagine the medication during pregnancy continue to harm the baby until the first few years of life. And those kids who are born from a mother taking Depakote, they will have mental challenges and intellectual problems more than someone who's not taking this medication. That's how serious we are when it comes to choosing the right medication before pregnancy. So again, there are safe medication, there are bad medication, and there's a lot of medication in between where we don't know yet. There's not enough studies to say this is a medicine that is good or bad. We kind of keep it in the middle, but there are safe medication that we like to use for every pregnant woman. Now, it's not only about which medication, it's about the number of the medications. So as we adding more and more medicine, the risk of complication during pregnancy will be more. So the ideal situation as we are planning is to choose safe medicine, minimize the number of the medication, and minimize the milligrams or the dose of the medication. And the fourth thing is to be on folic acid. Every woman with epilepsy is planning to have pregnancy, she needs to be on folic acid. That's just the rule. And that will reduce the risk of malformation in the baby, especially the brain malformation. Some of this medication might affect the brain growth in the uterus, and taking folic acid will prevent that kind of malformation with the medication. So remember, 4 things: safe medicine, then minimize the numbers of the medication, minimize the milligrams, and folic acid. If we do those 4 things in the time of planning, we should be okay. Next slide.
Okay, so we may sound like if we are reiterating, but we cannot say planning enough here in this presentation. So meet with your provider to discuss your history, diagnostic testing, and ascertain your diagnosis. Counseling will minimize the risk for any complications by doing interventions before and early on in pregnancy. Like Dr. Zakaria just said, it is important to mention that some anti-seizure medication may have an impact on contraception of choice. So again, that's why we ask all the women of childbearing ages with epilepsy to get on to supplementation with folic acid, because again, right, we are talking about planned pregnancies, but a lot of our patients, like Dr. Zakaria's example of the patient that he saw a couple of weeks ago, they come already pregnant, and we don't want to discourage our patients to obviously have that open communication with us. So, so it's important to let most women know that taking anti-seizure medication sometimes can play an effect on their contraception of choice. Again, folic acid supplementation, a must, prenatal vitamins. And as I just said, half of the pregnancies are unplanned, and all women of childbearing ages should be counseled. We counsel most of our childbearing ages patients to be able to get on the right contraception, of choice, and minimize any complications and do interventions earlier on. Next slide.
Okay, so now we're talking about pregnancy. So we talk about planning for pregnancy. We said the 4 things: safe medication, small dose, 1 medication if possible, being seizure-free, taking folic acid. Now, what happens after pregnancy or during pregnancy when the woman is pregnant and she's taking the seizure medications? Now, pregnancy, of course, is a very stressful condition on the body, not only physically but emotionally, without even epilepsy. So then you add the epilepsy to it, which will be more stress and more pressure on the body physically and emotionally. So we have to address that. We have to support the pregnant woman mentally and physically with everything we can in order to help her to go through the pregnancy without any problems or concerns. What I wanted to emphasize, the importance is of the body changes that will happen. This changes that every pregnant woman, whether with epilepsy or without epilepsy, they will go through during pregnancy. So as you may know, when a woman gets pregnant, there will be increase in the blood volume. There will be increase in the liver and the kidney clearance of the medications. And there's a change in the concentration of the protein in her blood. This is for all the women, whether pregnant, whether with epilepsy or without epilepsy. So how this will affect the seizure control and how this changes will affect the medication is very good question. It's very important question. Like I mentioned before, a lot of we will find that a lot of pregnant women, they might be seizure-free for years and years before pregnancy, and then once they get pregnant, they realize that they are having more seizures. And I think that's not because the medication is not working anymore, but because of these changes that happen in the body of pregnant women that affect the medication and will ultimately affect the seizure control. So I'll give you an example. Some of these medications that we use to control the seizures, when the woman gets pregnant, they will not last in her body the way they were before pregnancy. Because of the change in the liver and the kidney, the woman will be consuming this medication in a lot faster rate and will not be able to maintain the same level, even though they were taking the same milligram before pregnancy, same milligrams during pregnancy. However, the medication in the blood, the level of the medication in the blood will not be the same. So how do we fix this? If we know that if the woman is getting pregnant, she's taking one of the medications that can change during pregnancy, we have to be proactive during pregnancy. How do we proactive? check the level. We tell all my patients, Theo and myself, we have a list of patients, and when they get pregnant, we keep them on a periodic blood test to check the level every 2 months, every 3 months. We check the level, and whenever we see that level dropping down, we will adjust the milligrams. We'll go up on the milligrams to maintain that level to be at the same level. So we don't want for the woman to take the medication and then her level will start dropping down, and then she will have a seizure, and then after the seizure we say, oh wait, we have to increase the medication. We don't want that to happen. So how to prevent that? How do we prevent that? We prevent that by, we don't want to wait for the seizure. We cannot check the blood level, and we can follow up on the blood level every 2 or 3 months to maintain that same level that the patient had before pregnancy. In this way, we are maximizing our effort to prevent having any seizures or any complication during pregnancy. So blood work is very important during pregnancy. Even if there is no seizures, no concerns, still we need to do the blood work. We need to keep a very close eye on the levels and be sure that we are adjusting the milligrams of the medication to maintain the same level. And once we have the baby, then the question is, the body starts getting back to normal, and all this extra milligrams that we were taking during pregnancy, there is no reason to continue taking it, because otherwise the patient will be toxic, will be taking too much of the medication, and there is no reason. Now remember, the liver and the kidney are not as fast as the way they were during pregnancy. So we have to be very careful as we have the baby and the woman is going through the postpartum time. That's the time where we need to start going down on the milligrams in order to prevent any major side effects or toxic effect of this medication. Next slide. Oh,
yeah. Okay, and to continue on with what Dr. Zakaria was saying, also we want the moms to start coming down on their dose of medication, because they're going to start breastfeeding, right? So the more medication they take, the higher the dose of the medication they take, that's the more medication the baby could potentially be receiving. So that's important, not to stop the medication right away, but to talk to us, and we will continue the postpartum period care. Depending on how the patient is doing. So postpartum period and epilepsy. These are some of the common questions. Should I continue my anti-seizure medication? Should I go back to my pre-pregnancy dose? And most patients can go back to their pre-pregnancy dose or switch their medications back to whatever they were taking previously if they were changed within the first few months of postpartum, but this takes planning and conversations. Triggers can also be out of control during this phase. Because the moms typically endure sleep deprivation and increased stress. So we try to come up with a plan to prioritize sleep. We also offer them many support groups and resources available that can help them during this challenging time. We discuss safety. So safety during postpartum, just across the board, is no co-sleeping, and if the mom is having or have had active seizures, then we recommend always the mom not to be bathing the baby by herself. Always have like a second pair of eyes, mom, a dad or family member around that can supervise that. So no co-sleeping, no bathing the baby, not having the baby on like high surfaces when the mom has had active seizures. And breastfeeding. So this is where the communication typically continues. It started during their pregnancy appointments, but during the postpartum, a lot of patients have concerns about breastfeeding. So again, we always tell them that new studies show that moms are able to breastfeed, especially on the medications that we know that they're very safe, such as Keppra and lamotrigine. And we also encourage communication with the pediatrician to make sure the baby is doing well and gaining the appropriate weight and all developmental milestones. So taking anti-seizure medication is no longer contraindication to breastfeeding. Pumping should also be considered so that another adult can help with nighttime feedings to ensure that the mom gets enough rest. So in this period of time, we try to prioritize sleep, because this is a very common trigger for any of their episodes to occur. Next slide, please.
So this will be our final slide. I just wanted to give you a few examples of patients that I have seen in my office that I learned a lot from their stories. The first one is we were talking how pregnancy is not only physical stress on the body, but it's also a mental or psychological stress on the woman dealing with epilepsy and dealing with pregnancy at the same time. I know one patient. I saw her, I think, few months ago. So anyway, she has seizures, and her seizures are well controlled on medication. She got pregnant, and then she called the office, and she was having now seizures. And we thought, oh, maybe because the medication, we need to adjust the level, we need to do this and that and this. But she kept having seizures, and nothing really is helping. So we decided to do a test in order to see why she's having more seizures, because she was doing so well before pregnancy, and her medications are okay, and there has been no major change in the level of the medication. So anyway, so we did the test. The test was video EEG monitoring to get to see what kind of seizure she's having. And what we found is that actually what she's having is what we call non-epileptic seizures or pseudo seizures, which mean that she's not having seizures, she's having this episode as a result of major stress or psychological trauma that she has experienced through her pregnancy. And of course, the treatment for this kind of episode, the non-epileptic or the pseudo seizures, is not more medications, especially while she's pregnant, is doing more therapy and counseling. So that just gives us is some insight of the amount of the mental stress that a lot of women will go through pregnancy, especially when they also have to deal with epilepsy and taking seizure medication. The second story I want to mention, talking about breastfeeding. We mentioned, remember how we mentioned the medications for pregnancy? We said there are safe medication, there's bad medication, there's a lot in between. The same rule applies for breastfeeding. There are safe medication, there's bad medication, and there's a lot of medication in between. And of course, the same medication that are safe for pregnancy are safe for breastfeeding. So if you are taking a good medication, safe medicine during pregnancy, there will be no changes that you can expect as you are planning to have to breastfeed. We can maintain the same medication, but it's very important to watch the changes in the level, because remember we said that during pregnancy we go up on the level or on the milligrams, and then after pregnancy the level will be too high, so we need to reduce it. I remember a patient, she wanted to breastfeed so bad, and I was like, that's fine, you can breastfeed. And she was taking Keppra, and we kept pushing Keppra throughout pregnancy. It's kind of interesting story. So she came to my office in the postpartum time, and I asked her how she's doing and how the seizure. She was like, I'm amazing, I'm great, everything is good, I'm healing well, and the baby is great, and the medication is fine. There's only one problem. I was like, okay, what's the problem? She said, the baby is not waking up. He's always asleep, and I think that's good. They told me that the baby will not sleep the first few weeks after delivery, and my baby's sleeping all the time, day and night. And I thought of this, I was like, wait, maybe your Keppra is too high for you and the baby, and that's why your baby is asleep. And she thought that this is a great thing, and for me it was like a disaster, because we don't want the baby to be asleep that much day and night. So we did the level, we dropped down the Keppra, the baby starts waking up. I think he's not sleeping now, so the baby is okay. But that's how important it is to get more information from the patient and be sure that they are not experiencing, the baby is not gonna tell you, I am dizzy or lightheaded, or I'm not feeling well, or have blurry vision, or they will not complain about the side effects. So the mom has to be, the physician has to discuss with the mom what potential sign or symptoms that tells that the baby is not doing well on this medication. If he's sleeping too much, if he's vomiting too much, if he's crying too much, if he's very aggressive or restless or active, those could be potentially side effects of the medication. And you have to discuss with your physician about possibly reducing the amount or finding a way to treat the side effect. We finished with this slide. Remember, we said for the medications for pregnancy and breastfeeding, there are good medication, there are bad medication. There's a lot that's in between. We don't know, and that can be very frustrating to the physician and to the patient. My recommendation for every pregnant woman with epilepsy is that be sure that if you are taking one of those medications that we don't know, is to be part of a registration trial in which we are just collecting information. This is not only for Memorial, this is not only for Florida, this is a nationwide project that we just collect information of the medication, we collect information about the pregnancy, we collect information about the outcome of the pregnancy and also the outcome of the breastfeeding. So we will have a huge database of a lot of patients taking the seizure medication, and with that we will be able to draw more conclusion in regard to which medication is safe and which one is not. So when you put your name in this registration trial and you get all you provide all the information that they need, you are helping not only your family, but you're helping every single woman, pregnant woman with epilepsy throughout the country and throughout the world, because that's how we can get information about the medication and the efficacy of the medication and the side effect and the changes that happen during pregnancy. I think there's maybe 10 or 15 minutes left, so I would love to leave some time to have more questions or any comments from the audience. I really appreciate your time. I appreciate you being with us today and listening to this talk, and I'll be happy to take me and Theo will be happy to take any questions.
Hi, thanks. This is Kim Amigo. What a great topic and talk. Thank you. I have a question. I do receive patients, on other medications that, other than Keppra and lamotrigine. So I'm wondering, is Vimpat one that you would consider safe? That's one that I see a lot.
So, I mean, we've had patients continue their Vimpat throughout their pregnancy. So it's one of the ones that we encourage them to register under these North American AED pregnancy register, because it is still being studied. But our patients here from the office, and correct me, Dr. Zakaria, if I'm mistaken, but they have had healthy pregnancies, healthy the deliveries, and the outcome have been great. So we always encourage the patients to register themselves on the registry if they are taking any of the medications that are unknown yet.
Yeah, I agree. I mean, I tell you from my own experience, if my patient is taking Vimpat, I will not change. I think the risk, so you have to look at the benefit and the risk of changing the medication. Yes, you might think about switching to Keppra or Lamictal because we have proven evidence that they are safe, but you have also to deal with the risk of having seizures because this person might not respond to the Vimpat or lacosamide, and during that transition, there is a risk of seizures. And from our own experience, is that the risk of seizures during the first few weeks of pregnancy will be a lot more than the potential risk of the medication on the outcome of the pregnancy. So our approach has been in the office is that if patient is taking Vimpat and they get pregnant, we are not changing the Vimpat except if there's a reason for it.
Thank you.
Are there any other questions? Yes, Alice, go ahead.
Hi. So this will be my third pregnancy. My other two children are very healthy. I have epilepsy and I take Keppra and Lamictal. With my other two children, I never breastfed because I was too afraid of the risks. So my question is there a difference between taking the extended release versus like the regular medication and it being more potent in the breast milk?
Yeah, I mean, I think that the extended release medication, the reason why we like to use the extended release is because it provides this even concentration of the medication, so there will not be a peak. So like every time you take the medication, the not extended release, the regular medication, you get the medication, there will be a peak of the level in the blood and then goes down, and then you take the second dose and there's another peak. So there's this up and down throughout the day. After taking the medication for some time, it will be very much not too much of up and down, but there still will be some increase and decrease fluctuation. The point of taking, or the reason why we try to give patients the extended release is because is more convenient, it's easy to remember, and that's something very important for pregnancy, because a lot of women pregnancy, they say, oh, I cannot remember my medication. So taking the extended release will help to remember, because it's easier, it's once a day. The second thing is you try to avoid those up and downs and the higher level of concentration. So it's all theoretical, but maybe they're taking the extended release medication will continue with this smooth concentration of the level without the variation, and that might be good for the mother and good also for the baby without no need for without being exposed to the variation in the level of the medicine.
Oh, okay, thank you. Yeah, I've been on the extended release for most of my life now. So that's good news for me. I read something, Google telling me that it wasn't good for the baby, so I never knew.
Yeah. No, I mean, I think that there's a lot of, we do have a lot of patients who they were having side effects on the immediate release medications. And then once we switch them to the extended release, they feel a lot better. So definitely it will be a good thing for both the mother and the baby.
Thank you.
Of course.
I have a question, and this is in particular to a client of mine whose goal is to get pregnant. Is this safe for her, with taking her anti-epileptic medication, to get an epidural?
Yes, it's safe.
Okay.
I mean, the only concern I have is, the Depakote, which is not a good medication. She should not be on Depakote. But if she is on Depakote tends to increase the bleeding time, which means that the blood she will not have, I mean, there will be some delay in clotting for her. So if they are doing the epidural, she might have more oozing coming from the skin because of the effect of the Depakote on the blood clots. It tends to delay the formation of the blood clots. So that's the only thing I can think of with the Depakote causing this problem, but the rest of the medication should be fine. But anyway, Depakote is really it's the worst medication to be on, not only for the epidural, but for a lot more reasons. Like I said, the bad effect can last up to the first few years of life for the baby.
Thank you. And one last question. Is there a safer option, either C-section or natural delivery, or it's?
Yeah, so both are safe from the seizure perspective. So
Okay.
the goal is try to just be sure that the mother and the baby are fine with the normal delivery. If the OB physician believes that normal delivery will be fine, then we are perfectly fine with that. But we would defer to the OB physician experience in regard to whether it's a normal or C-section. From our end, both are perfectly fine.
Okay, thank you so much.
Of course.
Does anyone else have a question? Someone wrote in the chat, what about Aptium?
So Aptium is one of those medications that in the middle. Remember, we say good, bad, and in the middle. So the nice thing about the Aptium, it's once a day. So that's back to the extended release medications. So that's a good thing about the Aptium. The other thing is Aptium is very similar to another medication called oxycarbamazepine or trilaptol. And trilaptol is safe during pregnancy. So we believe, again, it's believed that Aptium will be okay for pregnancy, but definitely we'll recommend to get the EED pregnancy registration for women who's taking the Aptiom to get more evidence-based medicine, whether the Aptiom will be safe for pregnancy or not.
All right, we have time for one more question if anybody has one. Maria, did you have a question? Okay. Well, on behalf of Epilepsy Alliance Florida, we want to thank all of you for joining us. A huge thank you to Memorial Neuroscience Institute, Dr. Zakaria and Fiorella for your time and your wealth of knowledge. It's so appreciated. And thank you all so much. We hope to see you guys at one of our upcoming walks.
Sure, we'll be there.
Thank you.
Thank you so much. Thank you, everyone.
Thank you all.
Thank you.
Bye-bye.
Bye-bye.